ఓకే. ఓకే. మీరు రికార్డింగ్ అని ఏమైనా వస్తుందా? స్టార్ట్ రికార్డింగ్ అట్లాగేమైనా? అదే టైం చూసి స్టార్ట్ చేశాడు. అయినా ముందర నాకు మధు ఇంట్రొడక్షన్ ఇవ్వాలేమో కదా?
ఇంట్రొడక్షన్
అయిపోయిన వెంటనే స్టార్ట్ చేసేస్తారు.
ఇంట్రొడక్షన్ స్టార్ట్ మీరు ఓకే రెడీయా?
రెడీ అయినామా మనం?
Okay. A very warm good evening to all of you. I welcome you all once again to the Oculoplasty online course series by Subramaniam sir. I congratulate sir for successfully finishing halfway through the topic, and today's topic is very, very important. It's about thyroid eye disease, and we are lucky to have sir to discuss about today's topic. Sir, now I hand over the podium to you to take it forward, sir.
Thank you, Madhu. And a good evening and a very warm welcome to everyone for today's webinar lecture. The topic for today is thyroid-associated orbitopathy, which is very, very important, I consider, for the postgraduates, because it could be a theory question as well as it could be a long case. Whenever you get a prognosis, it will be a long case, and the most common case of prognosis, the most common cause is thyroid-associated orbitopathy. Even for general practitioners, it is very important to know, because more than 50 to 60% of cases of thyroid-associated orbitopathy do not have any inflammatory changes and do not have any compressive optic neuropathy, and most of them can be managed conservatively at your level. So, this is a very, very important topic, and I request you to pay attention. And because of its importance, I am doing a little more exhaustively, and at the end, you can ask me your doubts. Before I start the class, I would like to acknowledge the great role played by Dr. Jack Roseman and Peter Dolman of University of British Columbia, Vancouver, where I did my fellowship in 1998. And that's the time when they are coming out with the visa classification. I had a very good clinical idea of thyroid eye disease, its management, and also I was taught the thyroid orbital decompression and millerectomies, all these surgeries by Dr. Jack Roseman. So I owe a lot to these two people. As far as the thyroid eye disease is concerned, their role is very, very immense. Objectives of my presentation are that you should understand the clinical picture of the thyroid-associated orbitopathy at the end of this lecture. You should be able to classify a patient at which part it fits into, and should be able to diagnose, stage the disease, and plan appropriate management. So if you do all these things, which you should be able to, at the end of my lecture, I think I have succeeded in imparting knowledge of TAO. Let's start with the synonyms, because they may ask the question with one of the synonyms. It could be thyroid-associated orbitopathy, thyroid eye disease, thyroid-related orbitopathy, dysthyroid orbitopathy, Paris disease, Graves disease, or von Basedow disease. These three gentlemen are the people who actually gave the fundamentals of thyroid-associated orbitopathy, and so the disease is known by their names. The incidence and prevalence in USA is that about 160 females per million population per year get DAO, thyroid-associated orbitopathy, whereas 30 per million males get the disease every year. The age is mostly there in the 65 and above is 40%, 17 to 64 is 43%, and below the age of 16 years is only 10%. The thyroid-associated orbitopathy is the most common extrathyroidal manifestation of Graves' disease in the body, and it's very, very important as it is very frequent. The most common cause of proptosis, both unilateral, where it's more than 50% of cases of unilateral proptosis are because of thyroid, and bilateral, more than 80% of the diseases of bilateral proptosis are due to thyroid orbitopathy. There are varied symptoms which could be cosmetic, visual, and psychological. And we have to have a long duration of follow-up for the entire duration of the thyroid eye disease, which is 2 years. It could be associated with systemic condition of the thyroid disease, and often it is hyperthyroidism 92% as per the Dutton's classification article, hypothyroidism in 3%, and euthyroid state in 5%. But in my experience, hypothyroidism is about 60 to 65%, 15 to 20% are hypothyroidism, and euthyroid state in 10 to 20% in India. The disease have a peculiar course and it's self-limiting, and its duration is about 24 months. It's slowly progressive. There will be an active phase, followed then it becomes stable, comes down and becomes stable. And it is slowly progressive, could be acute when there is active phase. Episodes of active disease will be present, associated with painful myositis, which leads with fibrosis and motility restriction. The risk factors for TAO are smoking. Smoking is a very huge and avoidable risk factor. Those who have systemic thyroid disease, if they are smokers, nearly their chances of getting thyroid eye disease is about 6 to 8 times more than a non-smoker. Similarly, if a person has thyroid eye disease, those who are smokers have about 8 to 10 times more chances of developing compressive optic neuropathy when compared to a non-smoker. So smoking is a very, very huge risk factor, which fortunately can be avoidable, but even a passive smoker and even a past smoker has increased risk of developing compressive optic neuropathy. Uncontrolled thyroid dysfunction is another risk factor. High levels of thyrotropin receptor antibodies. Treatment with radioactive iodine can worsen the thyroid orbitopathy, and hypercholesterolemia can also be a risk factor for the development of TAO. Epidemiology is more common in females, and the difference decreases with age. 80% have a chronic or subacute disease, and 20% are acute and elderly. But actually, it's not 20%, nearly 40% it occurs in elderly. Hyperthyroidism is the most common condition. Hypothyroidism and thyroiditis are very rare, and the euthyroid state is seen in 10 to 15% of condition patients, more common in males, at least in India. Pathophysiology, known pathophysiology is that it is an autoimmune disease with antibodies targeting both TSHR, that is thyroid stimulating hormone receptor, and orbital fibroblasts. TSHR stimulation activates orbital fibroblasts. So that what is happening, the activated fibroblast produces cytokines, hyaluron, and glycosaminoglycans, leading to inflammation, adipogenesis, swelling, and fibrosis. Insulin-like growth factor 1, IGF-1, also activates orbital fibroblasts. So the most important key role is played by the orbital fibroblasts. There are different classifications. Nose specs by Werner, American Thyroid Association. Then CAS, Clinical Activity Score by Moritz of Amsterdam Group. UGOGO, that's the European Group on Graves ophthalmopathy or Graves orbitopathy, and visa classification by Peter Dahlman and Jack Whitman, my teachers. No specs classification, American Thyroid Association, 1977. To be honest with you, nobody clinically follows no specs classification of a case. I'm telling this for the sake of the theory. N stands for no signs or symptoms. Only signs limited to upper lid. Soft tissue involvement with signs and symptoms. Proptosis. Extraocular muscle involvement. Corneal exposure. And sight loss due to optic nerve compression. That clinical activity score is very important. That changed the game, to be honest with you. CAS is a retrospective study proposed in 1989. This is because previously they used to say that for every case of proptosis, give steroids as a test course. If it responds, it is thyroid orbitopathy. So they used to give steroids for every case of thyroid orbitopathy. Some are responding, some are not responding. When a retrospective study was done, they found that they respond only if there is a inflammation in only those patients. So then they started selectively giving these steroids only for those with inflammation. So clinical activity score is based on that. There are total 7 points. 1 point for orbital pain at rest. Number 2, pain with movements, hemosis, caruncular edema, eyelid edema, conjunctival congestion, eyelid congestion. These are nothing but the signs of inflammation. Pain, swelling, congestion, which are the 3 important points of inflammation that we know. European Group on Graves orbitopathy, UGOGO classification is divided into 3 grades: mild, moderate to severe, sight threatening. Mild, what are the features? There is no or minimal impact on life because of the disease. Lid retraction is less than 2 millimeters. Soft tissue is mild, involvement is present. Exophthalmos is less than 3 millimeters. Transient or no diplopia. There is lag of ophthalmos with corneal exposure, which responds to lubricants. No severe corneal problem. That is the mild disease. Moderate to severe. So this is the disadvantage in this UGOGO, in that they have not separated moderate, they have not separated severe. Both are clubbed together. There is a significant impact on daily life. Lid retraction is more than 2 millimeters. Moderate to severe soft tissue involvement. Exophthalmos 3 millimeters or more than 3 millimeters. Inconstant or constant diplopia. So the clinical picture is worsening, that is moderate to severe. Sight-threatening orbitopathy could be because of compressive optic neuropathy, also known as dysthyroid optic neuropathy, CON or DON, or corneal breakdown and melt due to exposure. This is sight-threatening orbitopathy. What is the scoring system in UGOGO? First is there are the 7 points of clinical activity score of Moritz. First 7 points. Next visit, there are 3 extra points. Number 1, 1 point for increase in exophthalmos 2 millimeters or more than the previous visit. Number 2, decrease in motility of eye 8 degrees or more when compared to the previous visit. Decrease in Snellen's visual acuity by 1 line or more is the 3rd point. So that there are total 10 points. 3 points in the first visit or 5 points in subsequent visits, you have to start treatment. So what are the recommendation of treatment in UGO? Mild disease, lubricants, head end of the body is to be raised, systemic thyroid disease is to be in good control, which is true for all stages of thyroid associated orbitopathy, and tab selenium 100 micrograms per day for 6 months is supposed to definitely improve the quality of life of patients of TAO. Selenium is one thing we have to add. Moderate to severe orbitopathy. IVMP, intravenous methylprednisolone, 0.5 grams per week for 6 weeks, followed by 0.25 grams per week for 6 weeks. That is a total of 4.5 grams in 12 weeks or roughly 3 months. If diplopia is severe, there is severe proptosis, there is a diplopia which the patient is suffering from severe soft tissue pathology, they recommend increase the amount of methylprednisolone. IVMP, intravenous methylprednisolone, 0.75 grams per week for 6 weeks, followed by 0.5 grams per week for 6 weeks, total 7.5 grams in 12 weeks. Plus mycophenolate 0.72 grams per day for 24 weeks. This is the treatment for moderate to severe orbitopathy. If the patient has compressive optic neuropathy, IVMP 1 gram per day or alternate day for 3 injections. If no response in 1 to 2 weeks, surgical orbital decompression is advised. This is the treatment recommended by UGO for TAO. So, pulse steroids, that is IVMP, versus oral steroids. Which is better? Pulse steroids are definitely much better because the response with pulse steroids is about in 82%, whereas response to oral steroids is in only in 53.4% patients. Pulse steroids, there are fewer side effects, shorter course, and lower relapse risk. For these reasons, pulse steroids are given rather than oral steroids. What are the contraindications for IVMP? Recent viral hepatitis, severe cardiovascular morbidity, liver dysfunction, severe hypertension, uncontrolled diabetes. In these situations, IVMP is contraindicated because the dose is very huge. Always get serum electrolytes, liver function test, and serum glucose levels done before starting IVMP. And to be honest with you, for all my cases of thyroid eye disease where I recommend IVMP, I do not administer. I'll refer the patient to the treating endocrinologist with my suggested treatment protocol, and the IVMP is given by the endocrinologist under his monitoring, usually with monitoring by ECG. Then the visa classification of Peter Dolman and Jack Whitman of University of British Columbia, Canada, which I follow. V for vision, that's optic neuropathy, defective vision due to optic neuropathy, compressive optic neuropathy. I for inflammation, which has lots of congestion, edema, and swelling. S for strabismus, due to ocular motility disturbances, because basically the extraocular muscles are involved. A for appearance, which is because of soft tissue changes and exposure. Vision, due to optic nerve compression. So the patient complains of defective vision. There will be color vision defects, as you can see. So every patient has to go through the color vision test. RAPD, relative afferent pupillary defect, will be seen. There can be optic disc edema in the fundus, or if it's a late case, that it may go into optic atrophy and pallor. Visual field defects can be seen, and CT scan shows apical prodding by the enlarged extraocular muscles, which is usually seen in the posterior one-third of the orbit, where the space is less, the muscles are big and thick and compress the optic nerve. What are the major risk factors for CON? Sex, gender, it's males. Males are predisposed or have higher risk of developing compressive optic neuropathy. But females who are in the fourth decade and above, and at that time they get the TAO, have equal risk as males. In other words, young females are not at a risk of developing compressive optic neuropathy. Age fourth decade and above. So patients who are in the fourth decade and above, when they develop this TAO, whether they are males or females, are at a higher risk. Diabetes is another risk factor, and all these three above risk factors are they cannot be changed. The only risk factor that can be changed is smoking, and you have to spend a minute or two in educating the patient not to smoke and why not to smoke. Race, they say that Caucasians and blacks are at higher risk of developing compressive optic neuropathy, but in my experience, we Indians also have the same risk of Caucasians and blacks in developing compressive optic neuropathy. The minor risk factors are acute onset of TAO, severe hyperthyroidism, and early onset of orbitopathy along with hyperthyroidism. The systemic disease and eye disease start almost at the same time. That is also a minor risk factor. Management. IV methylprednisolone, 1 gram on alternate days for 3 injections. If the patient is responding, it can be repeated 1 gram per week for up to 8 grams. Oral prednisolone proper over a period of 3 to 4 months, we have stopped doing that. It is just for theory. If the patient you can't give IV MP, then you have to think of oral prednisolone or other immunosuppressants. If there is no response in 2 weeks, surgical decompression should be done, followed by orbital radiotherapy. This is the management of compressive optic neuropathy as per VISA classification. So once you notice that there is a compressive optic neuropathy, immediately you are stepping in with IVMP, not responding, surgical decompression, responding, continue IVMP up to 8 milligrams, 8 grams, and if not responding, surgical decompression followed by radiotherapy. So radiotherapy is done both whether the patient responds or doesn't respond, we can subject them to orbital radiotherapy. Orbital radiotherapy acts by reducing inflammation. It affects the lymphocytes, leading to reduction in the cytokines, affects orbital fibroblasts, leading to reduction in their activity and reduction in glycosaminoglycans production. As I said, the chief culprit is orbital fibroblasts in TAO. So that is actually targeted by radiotherapy. Application, 200 rats per sitting for 5 days a week for 2 weeks. That's a total of 2000 rats with linear accelerators. It is indicated in optic nerve compression, diplopia, and active inflammatory disease. In all the three, it is radiotherapy can be used. It's contraindicated in diabetes mellitus, hypertensive retinopathy, and young patients, patients less than 35 years of age. Radiotherapy reduces inflammation, improves ocular mobility, and reduces diplopia. It should always be combined with oral steroids. A study was done by Ruthman and Dahlman on 351 patients who received orbital radiopathy. CON, compressive optic neuropathy, developed in 17% of those who received radiotherapy alone and in none who received radiotherapy plus oral steroids. So radiotherapy should always be combined with oral steroids. Orbital radiotherapy stabilizes the disease in 85% of the patients and may prevent the development of dysthyroid optic neuropathy. It may also be used in patients refractory to IVMP, patients are not responding to IVMP, and who refuse surgery, that is orbital decompression, or who are not fit to undergo such a major surgery, we can subject them to orbital radiotherapy. The second part of visa classification is hyperinflammation. So 10 points are given in this classification. Orbital pain with movement, 1 point. Orbital pain at rest, 2 points. Chemosis, conjunctiva behind gray line, 1 point. Conjunctiva in front of gray line, 2 points. Caruncular edema, 1 point. You can see caruncular edema here. Conjunctival injection, 1 point. Lid edema, 1 point. Lid edema with overhanging skin, either upper lid or lower lid, 2 points. Diurnal variation of periocular swellings and edema, 1 point. If inflammatory score is 5 or more, treat with steroids followed by radiotherapy. Here are 2 patients with low inflammatory score. In this patient, you can see there's a lid edema. Other than that, everything absolutely is normal. In this patient, there's a minimal conjunctival congestion in the right eye, nothing more. The inflammatory score is 1. There is edema, severe lid edema, lid congestion, conjunctival congestion, chemosis, and severe lid edema, conjunctival congestion, caruncular edema, pain. It is a high inflammatory score. Again, here you can see severe proptosis with lid edema, overhanging edge, conjunctival congestion, proptosis, and periocular edema, pain, high inflammatory score. Here is a patient with severe bilateral proptosis with grade 3 chemosis, overhanging the skin, right? Corneal congestion, caruncular edema, exposure keratitis, severe lag of thalamus, pain, and a very bad looking eye, very high inflammatory score. Management of inflammation. If inflammation score is 5 or more, then only we start treatment. How do we start? IVMP, intravenous methylprednisolone, 1 gram on alternate days for 3 injections, just like CON. Then review after 3 weeks here. There we review after 1 week and see whether it's improving or not. If good response, now further continuation of IVMP, subject them to radiotherapy. If there is no response, try other immunosuppressors. The patient is not responding to IV methylprednisolone, steroids, you try other immunosuppressors. If he is responding, go for radiotherapy. So, immunosuppressants could be azathioprine, cyclosporine A, methotrexate. But before you start, look for the liver function test and look for bone marrow depression, which may occur over a period of time with these drugs. So let's go a little into the commonly used immunosuppressants, non-steroidal immunosuppressants. Methotrexate indications in patients with active thyroid-associated orbitopathy who could not tolerate steroid or who did not respond to steroids. Route is oral by way of tablets of 2.5 milligrams each. Dose is if the patient is less than 60 kgs in weight, 7.5 milligrams per week, that is on Thursday, 2 tablets, that's 5 milligrams. On Friday, next day, 1 tablet, 2.5, and Sunday, 15 milligrams of folic acid. If the patient's weight is more than 60 kgs, it is for 10 milligrams per kg body weight. That is 3 tablets on Thursday, 7.5 mg, 1 tablet on Friday, total 10 milligrams, 15 milligrams of folic acid on Sunday. The duration of treatment is 1 year. It improves inflammation only, CAS only, clinical activity score. It has no role in optic neuropathy. Rituximab is an anti-CD20 monoclonal antibody, a B cell surface marker, causes B lymphocyte depletion directly and also causes apoptosis. Effect lasts for about 6 months. Dose 2 IV injections of 1 gram given 2 weeks apart. Infusion time is 3 to 4 hours. Side effects are severe like ulcerative colitis, arthritis, hypotension, transient fever, chills, pain. And the literature survey shows only case series involving 43 patients. Response is good, improved CAS, but no drug trials involving good sample size was done with rituximab. So that is the only drawback for this drug. Teprotumumab or Tepezza. It's a monoclonal antibody against IGF-1R, that's the insulin-like growth factor 1 receptor, which activates the fibroblast, orbital fibroblast. So it is approved by FDA only 5 years back on 21st January. Useful in active TU. All these immunosuppressants are used only in active disease where steroids are not useful, or patients are not responding to steroids, or patients are not able to tolerate steroids. In those situations only we are using. These are not the first line of treatment. Exception may be Tepezza. It is useful in active TAO. This is the only drug that reduces proptosis by about 3 millimeters on average, 2.84 mm on average. The dose is intravenous infusion over 60 to 90 minutes, 8 injections, once in 3 weeks. The dose is 10 milligrams per kg body weight for the first and second doses, then 20 milligrams per kg body weight from third to 8th dose. The powder is dissolved in distilled water. Roll the vial, don't shake the vial. Each vial contains 500 milligrams of teprotumumab. Storage. Vial and diluted vial can be stored at 2 degrees to 8 degrees. Diluted vial, the shelf life is only 48 hours. If you have some drug left, you have to use it within 48 hours when it is stored in a fridge at a temperature below 8 degrees, right? Otherwise, you have to throw it out. Side effects are severe like muscle spasm, loss of hearing, alopecia, nausea, hyperglycemia in 8% of patients, headache, worsening of IBS, inflammatory bowel disease, diarrhea. Is prohibitively expensive. Each vial costs nearly 15,000 USD. Total cost of the treatment is 200 to 300K US dollars, which comes to roughly about 2 crores, 1.5, 2 crores or something like that. Hopefully, but this is only that reverses the disease, that reduces the fibrosis, reduces inflammation, improves ocular motility, and has a great future. And probably what I feel is that down the road, about 15 years, we may be able to get this type of drugs over the very affordable prices, and then surgery of orbital decompression may take very backseat and may be very rarely performed. That is about inflammation. The third is, yes, strabismus, which is because of extraocular muscle involvement. The strabismus is progressive. There can be inflammatory changes early, especially with congestion at the insertion of the horizontal recti. Patient can have a morning diplopia, because when this disease occurs at the age of, let's suppose, 40 years, for 40 years, the patient had great binocular vision, single vision with excellent fusional reflexes. Once the motility restriction starts, when the patient sleeps in the night, there is no fusion. When the patient wakes up and opens the eye, the fusional reflexes and reserves are not at fully functional, and there can be diplopia. And as the fusional reflexes take over, over a period of hour or so, the diplopia disappears. This is inconstant or morning diplopia to start with. As the disease progresses, it can become constant. There could be congestion at the insertion of the recti muscles. And as the disease progresses, as I said, there will be fibrosis leading to scarring, and force reduction test will be positive, and there could be raise of intraocular pressure, because when the patient tries to move, the eyeball may not move, but the eyeball gets compressed between these thick, non-relaxing muscles, and the intraocular pressure may go up. Similarly, the intraorbital pressure can also go up, and that can also cause raised intraocular pressure. One person can have acute myopathy, and all these enlarged muscles, they lead to apical crowding and optic nerve compression. Strabismus has divided into certain points. Diplopia on lateral gaze, 1 point. On straight gaze, which is occasional, 2 points. On straight gaze constant is 3 points. If this is associated with inflammatory signs, start steroids and then radiotherapy. If there are no inflammatory signs, wax the eye or give Fresnel prisms till the course of the disease, and then at the end of the course of the disease, we will do surgeries. The surgeries done for this squint are only recession of the fibrosed muscle, no resections. Slit signs in TIAO, that's for the appearance of visa classification. Dalrymple sign, that is upper lid retraction in straight gaze, that you can see both severe lid retraction with scleral show, both the eyes. This is the most common sign. Van Graff's sign or lid lag on down phase, as you can see in both the eyes. Stellbach sign, infrequent blink. And to be honest with you, you have to read these from the textbooks. It is more of academic interest rather than practical interest. There could be corneal involvement because of lag of thalamus, as is seen in this patient. Minimal lag of thalamus with minimal corneal exposure in the right eye, and significant corneal exposure in the left eye. This lag of thalamus, lid retraction, incomplete blink, delayed or infrequent blink, tear film abnormalities, all can decompensate the cornea, leading to the formation of SPK. If not at a 2, it can lead to ulceration and perforation and loss of vision. What are the findings of CT in thyroid orbitopathy? Enlarged extraocular muscles with sparing of the tendon. There will be apical crowding. Crowding will be at apex only, because apex is narrow. The muscles bellies are starting at the annulus of gin at the apex. They swell and they compress the optic nerve. And there could be engorged superior ophthalmic veins sometimes. there could be increase in the fat because of adipogenesis that occurs, and the lacrimal gland may be displaced forwards. And if when both the medial recti are grossly enlarged, what can happen? The medial wall can excavate and it gives the Coca-Cola sign, like the shape of the Coca-Cola bottle. Here you can see grossly enlarged medial rectus and both eyes with Coca-Cola sign, sparing of the tendon. This shows the increase. This black is the prolapsed fat through the superior orbital fissure. This is how increased orbital fat volume is identified on the CT scan. And this arrow shows the lacrimal gland, which has been pushed forwards on both the sides. Lacrimal gland will be somewhere here, it has been pushed forwards in both the cases. What you see here in the axial cut is the enlarged, grossly enlarged inferior rectus muscle, and the sagittal picture show apical crowding in the posterior one-third. This is typically what you see. This is grossly enlarged inferior rectus in the apical and the sagittal section. Management, we have already discussed management. A few points that we have missed there. Review the patient with old photographs. When the patient first comes to you, ask him, when you ask him to come next visit, come with old photographs for the last 2 years where you can see the eyes in the straight gaze without the patient smiling. And in nearly 40% of patients, the disease exists for several months before the patient is aware of it. So that the duration of the disease we can establish and we know how long we can follow the patient. Reassure the patient. That's very important. It is house on fire analogy. When there is inflammation, when there is a fire, what we first do is we will douse the fire. We'll control the inflammation. We control the active phase of the disease and follow the disease till the course of is over. Then we start reconstruction. So the reconstructive procedures will be done. But the only exception is when there is a severe inflammation, when there is optic nerve compression. Control of endocrine disorder is very, very important. Avoid smoking. Monitor the patient regularly. I always ask the patient, because if you want to know when is the optic nerve is compressed, what is the first symptom? Optic nerve compression leads to color vision defect. The most simple and sensitive way of recording optic nerve compression is testing the patient's color vision. When the vision is normal, when the patient comes to you, we ask them for a review after 3 months. The optic nerve compression may start 2 weeks down the road. Then we'll be missing him for 2.5 months. So what we have to ask the patient is to purchase a red colored object, because red color is first affected in optic nerve compression. And look at that red colored object every Sunday. Close the right eye and look it with the left eye. Close the left eye and look it with the right eye separately. And he should be able to see the red colored object equally brightly. If it's bright with one eye and less bright with the other eye, probably that eye is going into optic nerve compression. The patient has to come to us immediately. I'm sorry. So that's how you have to monitor for optic nerve compression. Similarly, the patient has to come to us if he has developed severe inflammatory symptoms, pain, and diplopia. He has to come to us because we have to intervene. Otherwise, we'll see him once in 3 months. End of the bag to be raised up. Lubricants and prisms are to be used, that we have already discussed. The management strategies, as I said, are medical management, steroids, sheet anchor. If they do not respond, non-steroidal immunosuppressants. To be honest with you, so far I have not used non-steroidal immunosuppressant even a single case so far in the last 25 years or 30 years. Radiotherapy and surgery are the options. When you have followed for the 2 years of the duration, then it is inactive and residual disease. It is not going to further come back. This is true for about 95% of patients. The disease runs for 2 years. In 95% of patients, there is no relapse of the disease. It happens only in 5% of patients, there can be a relapse. So when the disease has become inactive after 2 years, and there is still a residual disease like a proptosis, motility, squint, and all lid positions, we go and start the surgeries. So what is the order? If there is a proptosis and the patient wants it, we first go out for decompression. If there is a squint, later after 3 months, we'll go for squint. After 3 months, we'll go for the lids. In this order, we'll do the surgical correction. Orbital decompression is indicated in the active phase when there is compressive optic neuropathy, and after in the residual stage, if there is a proptosis, which is spasmodic, especially it's unilateral, it's really bothering. If it is severe and bilateral, it will be really bothering. The routes are anterior routes, and we can do 1 valve, 2 valve, or 3 valve decompression and fat excision depending on the amount of proptosis. The way I was trained was with swinging lower lid approach. First, we'll do a lateral canthotomy, then do a cantholysis, and when the cantholysis is done, the lid can be easily moved away from the eyeball. Then make an incision below the tarsus and go through all the length of the lid. So you have a posterior lamella comprising of retractors and conjunctiva, and anteriorly you have the skin and orbicularis oculi. So in this plane, we dissect it down to the orbital margin. And once you reach the orbital margin, inside the orbital margin, periosteum, 2 millimeters from the orbital margin, and it is separated. And then you see the floor. In the floor, you make a ostium. I'll go up to 40 millimeters. I'll measure it almost from the rim to the apex. On either side of the, you will find a thumb through which the infraorbital nerve goes. So on either side of it, I'll make huge hole. Then medially I'll go, and the lamina factoriaceae can be easily broken, and laterally we can go and remove the lateral wall. We can drill the lateral wall, leaving a small bit of it, and we can make space through the lateral wall. And at the same time, we'll go peripherally and remove the fat, which I put in a syringe. The minimum amount of fat I remove is 3 ml, and if the proptosis is severe, I'll go up to 5 to 6 ml of fat. There could also be endonasal approaches through which you can reach the medial wall through the sinuses and remove the medial wall, or through the Caldwell-Luck approach, you can access to the floor by the endonasal route. I would like to spend a few minutes on thyroid-associated orthopathy, the Indian scenario, how it differs from the Western literature. This is more for your information, but you don't write this in the examination. Don't tell it to the examiners if you are a postgraduate, because the examiners may not be knowing this. My clinical data is about 373 patients. This is about 5 years old. And the male-female ratio is 1.16 to 1. Almost same. Whereas in the West, female is to male is about 5 is to 1. It is not true in India. The male-female ratio is 1.16 to 1. What is the thyroid status? In Dutton et al. Reported hypothyroid state in 92% of patients of TAO in America, Whereas for us, hyperthyroidism is only 70% of both sexes. Euthyroid state is more common in males, about 22%, 6% in females, and hypothyroid state is more common in females, 24% in females, and 8% in males. So the most common thyroid status is hyperthyroidism, both in males and females. Next is euthyroid state in males and hypothyroid state in females. When you take the age, there are two peaks in the incidence of the disease. The peak in the third decade, 34 males and 52 females, total of 86%. 86 people had the disease in the third decade. In the fifth decade, it is 83 and 57, total of 140. So average age, males is 45.1, females is 40.1 years. Range is 5 to 74 years. In other words, males are elderly by 5 years when compared to females. So there are two peaks in the fifth and seventh decade in USA, whereas it is in the third and fifth decade in India. So disease occurs in relatively younger individuals in India when compared to America. Males are 5 years older than females. TAO occurs in younger individuals in India when compared to the Western literature. If you look at the symptoms, my series, pain is only in 10%, whereas in Caucasians, Americans, it is 30%. Redness, 11% and 34%. Proptosis is more common in Indians when compared to Americans. Defective vision is 10 point is equal or a little more in Indian. Why this difference in the symptoms? The pain and redness are symptoms of inflammation. So inflammation is more early and more severe in Americans, so that they come to the doctor much earlier than without the symptom of proptosis. That is why the symptom of proptosis is less when compared to Indians, because in Indians, the inflammatory symptoms are less, so that they wait till the proptosis becomes gross and then they come to us. So that is the difference in symptoms. If you look at the signs, again, lack of thalamus is more common, 3 times more common in Indians when compared to Americans. Lid retraction, lid lag, diplopia, myasthenia, periorbital myxedema, not much of a no statistically significant difference in both the series. Okay. Lag of thalamus occurs nearly 38.8, nearly 40%. Caucasians, it is 12.7%. Severe corneal involvement is seen in 2.1% in Indians. And this patient has actually come with just PL both eyes for visual handcuff certificate. This is a patient of bilateral thyroid orbitopathy with corneal leucoma because of corneal involvement. So it's quite common. And now we'll go through certain case studies. This is first case. This male, 51 years of age, diabetic and smoker, has proptosis of 3 months duration. Exophthalmos is 26 and 27 millimeters on hectares. RAPD, relative apparent pupillary defect present. Best corrected visual acuity 6/12 right eye, 3/60 left eye. Intraocular pressure is raised. Optic disc edema is present. If you look at this, analyze is a male, high risk for development of COA. 51 years of age, and the risk factor. Diabetes, third risk factor. Smoker. So he has all the 4 major risk factors to develop compressive optic neuropathy. Came with proptosis of 3 months duration. That's also a minor risk factor, short duration. So vision is 3/60, 1 eye 6/12. And what does the CT show? CT shows bilateral proptosis with severely enlarged extraocular muscles sparing the tendon, all right, and with compressive optic neuropathy more clear. So I did a, since it is a, at that time, this is long case, IBMP is not available, this is about 30 years back. So I did a bilateral 3-wall decompression to swing in low eyelid approach and fat excision about 3.5 to 4 cc both eyes. And post-operative, exophthalmos has come down to 21 millimeters. There's a reduction of about 5 to 6 millimeters. Vision improved to 6/9 and 6/18. He was rather lost to follow-up. He was not interested in the eyelid surgeries. This lady, female, 49 years of age, diabetics, proptosis of 11 months duration, with defective vision of 3 months duration. So, though she is a female, above the age of, from the 4th decade onwards, she has the same risk as a male because of the age 49 years. Diabetes, 3 of the 4 major risk factors she has. Defective vision since 3 months. She has bilateral lid retraction, lid lag ophthalmos, exophthalmometry 28 and 29, intraocular pressure 28 and 34, RAPD, best corrected vision 6/12 and counting fingers 1 meter only. Color vision right eye 6 plates out of 17, left eye no 0, could not read, and bilateral optic disc edema is present. So the CT shows very grossly enlarged, all the muscles are grossly enlarged, all the recti and the optic nerve is getting compressed both sides. There is a compressive optic neuropathy. Underwent again a bilateral 3-wall orbital decompression with fat excision up to 6 cc from each eye. Post-operative Hertels has come down to 19. One important thing here is there is a lot of lid retraction pre-op that has disappeared. That is because I feel that mechanically when there is a lot of proptosis, the eyeball can separate the eyelids and there could be lid retraction, which was not described in textbooks. When once the eyeball goes back to its normal position, the eyelids have come down to their normal position and there is very minimal, probably 1 millimeter of lid retraction. She was, and the profile pre-operative and post-operative, you can see that this entire amount of fat has been taken, intracorneal fat has been taken. The eyeball which has been propposed now has gone back to the normal level. Mid position, you can see it has come back to normal. And the important thing is the vision has come to 6/5 right eye, and to my surprise, it is 6/6 in the left eye. It is real, honestly speaking, the vision has come down from pointing fingers 1 meter to 6/6. And one important thing here is you can see that by swinging lower lid approach that I did, there is very minimal scar that is visible here, and she looks absolutely fantastic. No marks of any surgery. And this is the visual field which was grossly affected pre-op in the right eye became normal. Under case, male, 47 years, so 2 risk factors, presented with proptosis of 1 year duration, bilateral proptosis, Hertels 25 and 26 millimeters. The right eye is hypo, L/R, with defective elevation, RAPD present, vision right eye 6/18, left eye 6/6, right eye shows optic disc edema, color vision only 3 plates, IOP 12, differential IOP, and on an attempted upgate, it is 34. So it is positive. Gold photos show lid changes since 16 months. That's what I'm saying. So they believe that they have the disease since 6 months, but the gold photos may show minimal lid retraction and subtle changes, which they might have missed. And so the duration of the disease from 6 months becomes 1 year. Right? Here you can see the patient with a right hypo and no defective elevation. CT scan shows enlarged muscles, apical compression on the right side. You can see gross enlarged. Even in thyroid, the other eye also will show enlarged muscles. Again, a 3-wall decompression has been done with about 4 mm of fat excision, and later waited for the entire course of the disease to be over, and then inferior rectus recession has been done, and this is how the patient finally on straight gaze, pre-op, post-op, both eyes have come to the straight gaze, and the light reflex percutaneous, you can see that it is in the center of the pupil, and the elevation has been restored, and there is no diplopia. The patient is very comfortable. This is under case, proptosis of 6 months duration, RAPD present, vision 6/18, color vision is 9 out of 17, reference 26 and 20 millimeters. What to do? So, in this situation, if we look into the visa classification, there is a compressive optic neuropathy. So, first give IVMP, then we'll go for, if it doesn't respond totally that to the IVMP, we have to do orbital decompression. So, the CT scan we have to see, the CT scan shows enlarged extraocular muscles with optic nerve being compressed in the posterior third, both in axial as well as coronal sections. After 3-wall decompression and fat excision, vision improved from 6/18 to 6/6, and see that the proptosis has grossly reduced. You plan the treatment. I'll show the first picture. Wait for about 30 seconds for you to think. Then I'll explain the plan of treatment. Because if it were to be a direct lecture, I can ask the students to get up and interact, but that cannot happen here. So just we'll see. Case 1. This lady has a bilateral proptosis of 6 months duration. Vision is 6/6. Color vision is normal. No RAPD. Inflammatory score is 2. Ocular movements are full. What to do? So she is about 35 years of age. Bilateral proptosis of 6 months duration. Normal vision. No color vision abnormality. No RAPD. Inflammatory score 2. As you can see, minimal conjunctival congestion and a lid edema. Nothing more than that. What will you do? Now, I'll start how to manage, how to plan for this. Now, as per the visa, first is vision. Your vision is not compromised. There's no compressive optic neuropathy. The second is eye inflammation. Inflammatory score is only 2. If it is 5 or more, then only we start steroids, IVM, and then radiotherapy. Since both are okay, our squint is 0, OM full, no squint. Appearance, there is bilateral proptosis with mild lid retraction. Appearance is there. What we'll do? We'll wait, follow the patient, and the duration is only 6 months. So we have to follow the patient for another 1.5 years. Then, if the disease progresses, then accordingly we'll act. If disease is like this only, if it doesn't progress, at the end of 2 years, if the patient is interested, then we can do orbital decompression. Follow the case till the duration of the disease. Lateral orbital decompression was done. This is a cosmetic, this is a residual disease with bilateral proptosis. Sorry. For which we have done a cosmetic orbital decompression, and that's how. Then for the lid retraction, we did a I did a Miller's rescission. That's how the patient was looking down the road. She is a happy patient. Another case, bilateral proptosis of 3 years duration. Arterals is 20 millimeters both eyes. Vision is 6/6. Ocular movements are full. Plan treatment. Again, I'll repeat it. Bilateral proptosis of 3 years duration. Arterals is 20 millimeters. Vision is 6/6. OM, ocular movements, full. Plan treatment. This is a bilateral proptosis, but arterals is only 20 millimeters, not too great. So normal limit is up to 20 is normal. So it looks very prominent. Why? Because of lid retraction. It is 3 years of duration. So this is a residual disease, not an active disease. Randall's curve is past. It's a residual disease. So we can add. As for the visa, vision is normal. There's no inflammation because it is a residual disease. So what we have to do? We have to do surgeries to improve the appearance. Is there need for orbital decompression? No, because arterals is 20 millimeters. So the residual procedure, what are the 3 surgeries? Orbital decompression, squint surgery, and then soft tissue or lid surgery. Vision is normal, so there is no need for that. Orbital decompression is not necessary because there is no proptosis. It's apparent of the normal. Squint surgery, not necessary, not needed. Ocular movements full, no diplopia. Eyeball is in the center. So what we have to do? We have to attend to the lids. And what does he have? He has lid retraction. So what we can do? We can do a Muller's rescission, upper lid, and also inferior extractor rescission, lower lid, and that's how the patient is. Now, after surgery, this is the pre-op and this is the post-op. You can see that now there is no proptosis. No apparent proptosis, to be honest with you. It's not a real proptosis. Case 3, male, 45 years, bilateral proptosis of 2.5 years, vision both eyes 6/6, arterals 23 and 24. What to do? Plan the management. If the patient comes like this. He is a principal of an engineering college. He had bilateral proptosis. And what do you see? You can see there's a bilateral proptosis, severe lid retraction. Eyeball appears to be in the center. Vision is 6/6. Again, look at what is the duration? 2.5 years. That means the course of the disease is over, and this is a residual disease. Vision is normal. So again, looking at the 3 surgeries that we can do, orbital decompression, is there indication for it? Yes. Why? He has bilateral proptosis. Unlike the first case where the arterals were 20, the previous case, here it is 23 and 24. So we have to first do bilateral orbital decompression. So cosmetic bilateral orbital decompression was done, 2-wall decompression with 3 mm of fat excision, and that's how he was looking down the road. But if you can see typical lateral flare, that is typical of thyroid eye disease, where the highest point of the lid will not be at the junction of middle and medial, but moves laterally. You can see here also, the highest point is here. It should be here. So this is the typical lateral flare with minimal lid retraction is still there. So orbital decompression is over. Then next surgery what? In the order squint. There is no indication for squint surgery because the eyeball is primary in the ortho position. There is no ocular motility. There is no diplopia. So there is no need for squint surgery. So then he is unhappy with the lid position. So what we can do? We can do Miller's surgery. So what I do? I did Miller's rescission both sides, and this is how the patient was looking. So a gross improvement, and he was quite happy from the stage he came to at this stage what it is. Here I would like to share my experience with an interesting case. This female, relatively young, 32 years of age, hyperthyroid of 4 months duration only, on neomercazole, came with severe bilateral proptosis, pain, redness, watering, and all problems with defective vision, 6 by 18 right and 6 by 12 left eye, RAPD present. Color vision is 9 out of 17. Optic disc edema present. Inflammatory score is 8. And you can see that fluorescein staining, punctate staining is positive on the cornea. CT shows grossly enlarged in medial rectus and the lateral rectus with sparing of the tendons. So when she came, I have put her on. So this in the active phase of the disease with optic nerve compression, visa classification, inflammation is also there. So we'll start with medical decompression of the optic nerve, that is IVMP, intravenous methylprednisolone, at a dose of 1 gram on alternate days for 3 injections. So, and I wanted to see her after 2 weeks. She said that she will take it at her place, which was Khammam. She went there. And after 2 weeks, she made a call saying that because of some situation at home, she could not come immediately to my workplace. That's the reason where I was working at MIMS at that time. So I asked her to take IVMP 1 gram per week. So she has gone for 6 weeks, that is up to 8 grams. Then she came to me after 8 weeks. So after IV methylprednisolone 8 grams, inflammation reduced, but vision worsened to 6 by 60 right eye and 6 by 36 left eye. So IVMP, in most of the patients, it acts as a medical decompression, but not in every case. That's why what we said initially in the treatment of vision, if it doesn't respond in a couple of weeks, go for surgery, surgical decompression. If it responds, you can continue IVMP and then RP, and then you can take care of the situation. So we have to do orbital decompression because it is not responding to IVMP. So I did a 3-wall orbital decompression, and fat excision about 3 cc plus Muller HME because of severe lid retraction. And then the Hertels has come down to 18 millimeters, vision improved to 6 by 5 both eyes. So this is to the important points here are that she is a female, relatively young female, she non-diabetic, not very big, age is also not great, non-smoker, still she got a bilateral optic nerve compression which did not respond to IVMP. So these are the important points here. So this is how the patient was before surgery and after surgery. This is the incision mark of lateral orbitotomy with swinging lower lid orbital decompression 1 month down the road. So the take-home messages are, it's more common in females and also in hyperthyroid state. Active phase of the disease can last for 24 months. Compressive optic neuropathy or dysthyroid optic neuropathy. The risk factors are males, elderly, smokers, and in diabetics. Color vision is very simple and accurate for recognizing or diagnosing compressive optic neuropathy. I follow the visa classification because with that we can stage the disease and it gives proper guidelines how to treat the eye and each disease. I find this much more straight and direct when I compare to Yugovo. And what I find is that Yugovo is more commonly followed in European countries and visa in North American countries. The management strategies are observation medical management, radiotherapy, and surgery. The surgeries, especially for residual disease, or decompress if necessary, then squid surgery if necessary, then lid surgery if necessary, with a minimum gap of 3 months between each surgery. Thank you all.
Thank you, sir. Thank you so much. I think it was a really great lecture. And it's not a joke to continuously take a lecture nearly for 1 hour, 15 minutes, I think, as sir has told. Thank you,
Yeah.
sir. Thank you so much for taking the efforts to bring this together. So we would like to make a small announcement for the next 2 weeks. We'll be taking a summer break. And we'll be back. We'll be back on May 2nd. If some PGs are in. Sorry. June 2nd, if case presentations are there, or June 9th, we'll resume our trauma class. June 9th will be trauma class. In case we have some interesting cases that can be discussed, June 2nd, sir will be happy to moderate that session for us. Thank you, sir. Thank you so much once again.
Thank you, Madhu.
Sir.
Thank you all.
Thank you, sir. Thank you, sir.
Yeah.
Questions?
Left,
I
sir.
think there are no
Left, sir.
questions.
Left, sir. There are no questions.
Okay.
Thank you.